Hei og velkommen til denne serien om klok og riktig legemiddelbruk, hvor vi skal møte noen av våre fremste eksperter på området. Medikamenter er et potent verktøy som har hjulpet millioner av mennesker med deres plager og reddet mange liv. Men som ved ethvert potent verktøy så må det brukes ved omhu. Ved feil bruk så kan det gjøre langt mer skade enn nytte. I denne serien så skal vi møte 3 eksperter som har fordypet seg i klok bruk av legemidler. Hvordan vi kan få mest mulig nytte og minst mulig skade. Hi and welcome back. This video is going to be in English and we'll be discussing a topic that I know is important to a lot of people, and that is the use of medicine in pregnancy. When you're pregnant, you're not only concerned with your own health but also the health of the fetus inside of you. Medicines that are important to you may potentially be harmful to the fetus. To tell us more about this, I'm now joined by Dr. Angela Lupattelli. Welcome.
Thank you.
You are especially interested in epidemiology, drug safety during pregnancy, and perinatal mental health. So tell us, do you think that we doctors are a bit too careful when it comes to treating pregnant women with medicines?
Yes. I would like to start answering you by saying that pregnant women have often been considered drug orphans, meaning that because of historical reasons and the thalidomide disaster back in the 60s, inclusion of pregnant women in preclinical randomized clinical trial has been, of course, limited. And therefore, the knowledge that we know about risk and benefit of drugs in pregnancy are generated using observational data. And therefore, I do understand that doctors, of course, they have to do thorough assessment, and they're worried about prescribing to pregnant women because the knowledge we have is generated by kind of data where it's difficult to assess causality. So whether the drug can actually cause harmful effect on the fetus. Mm-hmm. However, at the same time, during these last 2 decades, this knowledge for specific drugs especially has been generated. And therefore, I think that it's important that doctors have to do an individual-based assessment of each woman per se, but also have to be active in accessing evidence-based knowledge about what we know about a specific drug. And I think in Norway, for instance, we are lucky enough that we have nationwide health registry data where we can link information from the birth of the woman, how the pregnancy went, what kind of condition she had, and also we can link this data with the prescription that she has been filling at the pharmacy, so that we can generate, by using this data and new methods for to generate more information about causality, generate information about the safety of many drugs. So we hope that our research can be helpful to physicians and healthcare personnel at large, and to women in taking more informed decisions when it comes to treatment with medication in pregnancy.
We'll get more into that soon, but you mentioned something about the thalidomide scandal.
Yes.
I'm not sure all of our viewers are aware of what that was. Can you just shortly tell us what that was?
Yes, thalidomide was a medication that back in the 1960s, it was marketed in Germany and then after that also in other countries. And it was advertised as a safe drug to take during pregnancy. When I say safe, meaning that preclinical testing had been done in rats. And these studies in animals did not show any teratogenic effect. And when I say teratogenic, I mean effects such as congenital anomalies in the child. And this medication was taken by women to treat nausea and vomiting, and also to be a bit relaxant for anxious symptoms during pregnancy. So it was used widely. But then there was actually 2 doctors, Dr. Lenz and Bright, one in Germany and one in Australia, that very close in time they published letters that they noticed specific abnormalities, especially limb defect, in children born to women who had been exposed to this drug, which was marketed as a safe drug. And after that, closer assessment revealed that it was due to thalidomide that these children were born with a specific limb defect. And by this time, where the signal was actually evaluated and seen, I think it was about 10,000 children that were born worldwide with phocomelia, this specific limb defect.
Yeah, so that incident was understandably very important,
Yes.
historically, in the understanding of use of medicine and side effects in pregnant women. So it was very important in that matter. I would like to draw your focus to a more specific topic now. As you may know, a lot of women, or some women, experience depression during and after pregnancy. And we also know that antidepressants are some of the most widely used medicines generally in the public.
Yes.
So, and they're also quite debated. They are controversial still. So I would like to ask you, what about women that are pregnant and are clinically depressed? Can we treat them with antidepressants?
Yes, it depends. There are many factors that physicians and clinicians have to consider, and also women, when they decide or not to be treated with antidepressants in pregnancy. Of course, very much has to say the severity of the mother and how much she needs the drug to actually be functioning and to be able to carry on the pregnancy and also to take care of the child after birth, because I think that's an important point to consider. But of course, we have to weigh this potential benefit to the mother against potential risk of these drugs to the fetus and the mother herself. During the last 20 years, I think we have been generating knowledge, the research field, regarding short-term and long-term effect of these drugs during pregnancy. And when it comes to congenital anomalies, it has been pretty much consistently found across studies that these drugs are not major teratogen. But however, there are concerns for more subtle affecting the child, like for instance prematurity or low birth weight. But again, the absolute risk of this specific outcome is not that large. If we think of prematurity, maybe the difference in gestational age between treated and untreated, maybe 2 days, is short.
How have you obtained that knowledge? The studies that your group presumably has also carried out, is that observational data, or how do you have this knowledge?
Yes, in pregnancy research, we do have to rely on observational data. So in Norway, we have nationwide health registries, like the medical birth registry, where we capture information about the gestational length or the weight at birth and congenital anomalies. And we are able to link this data with the prescription records. However, in Norway, we have one of the biggest pregnancy cohort worldwide, which is the Norwegian mother, father, and child cohort study, which has recruited more than 100,000 mother and children and father in 1999-2008. So most of our research is based on this cohort study, following up pregnancy and also the children after birth, linking to this data with the national health registries. And I think this is a wonderful data source that we're very much lucky in Norway to be able to use it, because it gives us the possibility to measure important confounders or factors that can affect, can bias our estimates, right, when we do this research, like, for instance, the severity of maternal depressive and anxiety symptoms throughout pregnancy, which is an important factor to consider when we want to assess causal negative effect of antidepressants.
Yeah. So, as a clinician, these patients come to me, and as you said, I have to weigh the benefits against the risks of giving a certain medicine. I feel that it's easy for you to say that as a researcher, but much more difficult for me to do as a practical clinician.
Yes.
So do you have any advice for me? How can I make better decisions regarding these dilemmas?
I think one important advice is that each woman, or for each woman, we should tailor the counseling specific to her. So it's important to consider, first of all, at what stage in the pregnancy she is. If she's planning a pregnancy, or she's already pregnant and she's considering whether to take antidepressants or not. Or maybe she actually in the second trimester and now she's feeling much better in terms of mood, but she was exposed to antidepressants in first trimester. So she's wondering maybe how that drug exposure could have affected. But as a clinician, I think it's important to take the decision whether to be exposed to continue or not an antidepressant together with the woman. And the family, her partner, is also part of the conversation. And it's important to consider the overall picture of the evidence.
Yeah.
So it's important to weigh risk for immediate outcomes, as I mentioned, congenital malorrhea, prematurity, but also possible effect on long-term sequela if we think about ADHD or autism. And that's what our research is also focusing so much into. And then we need to weigh this risk in terms of absolute measure. I mean, a relative risk of 2, for instance, can sound very large, right?
Yeah.
Women taking the drug have double the risk of those not taking it. But then when we consider how common is the exposure in the population and how common is the outcome, the event that we are considering, we might realize that probably the risk in absolute number would not be so large for the woman. And also something that unfortunately our research has not been so much on the pace is like what is the benefit of the treatment for the woman given the specific characteristic of each individual. And that's something that we are trying actually now to generate this sort of knowledge. What is the benefit of antidepressant treatment at different stage of pregnancy for different severity scale of the woman and according to the genetic makeup, how a specific woman will respond to the drug. Because we see that women overestimate very much the risk of antidepressant exposure in pregnancy, and sometimes it's very easy to forget about the benefit because of course we want to prioritize the health of our child.
Yeah.
But
I don't think overestimating the risk is something that especially pregnant women do. I think it's very difficult for everyone to understand the concept of risk. We often overestimate the dangers, and it's not so easy in that situation to stay rational and look at the data. But are there any online resources and decision-making tools, both for me as a clinician and for pregnant women, where you can look up these things and get more information?
yes, there are. It has been developed, especially in Canada and the UK, and tested actually in a randomized clinical trial, a decision aid tool specific to antidepressants. And that's not a tool which aim is going to replace the role of the physician. It's a tool to facilitate the conversation and the decision-making process between the woman and the doctor. And in few words, this tool is an online, is made by modules online where the woman can go through and read in the summaries about what we know, what's the status today about the risk and the benefit of antidepressant, given specific set of characteristics of the woman. And the woman can go through all these modules, and at the end, she can have a better understanding of what is actually the absolute risk of this medication in pregnancy and weigh that against her need of the medication. And together with the physician, she can have a more informed conversation about her need for the drug, weighted against what she feels could be the risk for her child. And so, very interesting results from Canada and the UK. They see that this decisional aid tool decrease the conflict that the woman and the doctor, the dilemma they have around the decision making for treatment.
Yeah.
So it would be very nice and interesting to test it also in Norway to facilitate the decision making.
Absolutely. Great. So, Dr. Lupattelli, thank you so much for sharing your knowledge with us, and thank you to you guys for watching this episode.